Thank you very much and a very good morning to all of you. So today I'll be speaking basically on discoid meniscus, a condition that we see quite often, but I think there's a lot to know from what happens exactly in a discoid meniscus. So discoid menisci, as we all know, we're commonly tuned to thinking that discoid are on the lateral side, but you'll be surprised that discoid meniscus may also happen on the medial side, and medial side variations are also not uncommon. The discoid medial meniscus is one such variation, and a ring medial meniscus is another such variation. Of course, the discoid medial meniscus is far less than that on the lateral side. So if you look at the lateral side, it's not uncommon that we see discoid lateral menisci. Fortunately for us, we see less of them. The Japanese and the Oriental race is more prone to having these particular problems. And usually, it's going to be the young kids who are going to be roughly between 10 to 15 who are going to be coming with this pain, with the parents noticing the presence of a swelling on the lateral side of the knee and the presence of a painful click, especially when they start getting into sport. If you look at the discoid lateral meniscus, you have certain variations of the same, and you can classify them based on the arthroscopic morphology or based on the stability criteria, depending upon whether it is a complete discoid, an incomplete discoid, whether it is stable and unstable. And I think this is by far the best or the most practical way to look at them, since that really determines what is going to be your treatment plan. If you look at the morphological classification, the Watanabe classification is probably the best understood of all the available classifications on discoid lateral menisci. You have the type 1, which is a complete lateral discoid meniscus, which is completely stable, which means it is not displaceable. You have the type B, which is the more common one that you see in clinical practice, which is a partial type of a stable lateral discoid meniscus. It will cover less than 80% of the plateau. And you have the type C, which fortunately for us is the less seen of all of the three, which is a completely unstable pattern. In this particular pattern, as you see here, there are only attachments posteriorly. The whole anterior half of the lateral meniscus is completely unstable, and you can completely flip it in and out of the joint, and these are the ones that become symptomatic pretty early. These are the ones that are going to require aggressive repair with complete reattachment of this lateral meniscus back to its peripheral rim. So if you look at the peripheral rim stability of a lateral discoid meniscus, you will find that anteriorly it is more often unstable, followed by posteriorly, and least will be in the mid-third area. The diagnosis, as all of you are very well aware of, it's going to be younger kids who start playing sport and they start getting a painful, loud thud on the anterolateral aspect of the knee, which occurs as you extend the knee from a flexed position. Of course, do not forget to examine the contralateral knee, because you will get a fair amount of information there as well. So why do these discoid lateral meniscus tear quite easily? The reason being is the abnormal thickness and the abnormal vascularity. And the typical tear that you will notice is going to be a horizontal cleavage type of tear, and this happens as a result of delamination, and sometimes as you leave it going, then you may start getting complex tears as well, which then make them more difficult or more sort of not that amenable to a proper surgical repair. So here we're looking at a type B repair. This is a Watanabe B, which is a stable type of repair in which there is a horizontal cleavage tear. The key is to try and probe this tear completely, try and find out whether it is stable or unstable. And once you notice and once you figure out that there is an horizontal cleavage component that has occurred in this unstable tear, then you need to start repairing and stabilizing it. So how are you going to treat it? You are going to probe the tear in its entire entirety. Then you want to resect with the help of your mechanical devices, either by using basket punches of various configurations or by using motorized shavers. You want to trim out the meniscus to leave behind a stable, balanced periphery. This periphery should at least be close to about 10 millimeters in an adult and about 7 millimeters in a child. Often you will see this fish mouthing type of appearance, which is then noticed. You need to go ahead, rasp this area, try and freshen it so as to incite bone healing. The use of a fibrin clot within the horizontal cleavage or a PRP clot within the cleavage may help or assist in doing a better repair. Any loose flaps at this end has to be trimmed so that you get a nice stable margin. Then, depending upon the suitability of repair, the surgical skill that you're well versed with in the type of repair, as well as the zone of the tear, then you start proceeding with a meniscal repair. And in the previous talk, Anil has shown you a variety of various methods as to how you can repair these type of menisci. So my preference would be that posterior to the popliteus, I will always use an all-inside device. There are a variety of these available in the market. And then you want to do a vertical mattress stitch when you're doing an all-inside repair in this location, because you want to close the mouth. So you want to have one stitch on the superior lip, and you want to have the second stitch on the inferior leaf. And when you cinch down this repair, the whole mouth closes in this particular fashion, leading to a stable rim. If you go back to Parag's talk, when he discussed about the anatomy, you would definitely have understood and remembered that it's only going to be the peripheral third that takes about 80% of all the fibers of the meniscus, and hence even if you leave behind a peripheral rim of 80%, that takes care of most of the problems and most of the hoop stresses of the meniscus. So in the end, what you would want to see is that you'd want to see something like this, in which you've created a nice rim of the meniscus which is completely stable. You've not impaled the popliteus, and this is a view of the same one from an anteromedial portal looking at a properly repaired discoid meniscus. How are you going to diagnose it? If you see any suspicious lateral space widening with squaring of the condyles, that's important on an MRI scan. If you see the presence of extension of the lateral meniscus, which is more than 80%, or on successive 3 views, if you see a complete bow tie appearance in 3 consecutive images in the sagittal sequences, that becomes an important aspect. A word of caution, I think as clinicians we are better concerned to diagnose meniscus tears than probably MSK radiologist. So to conclude, the discoid meniscus presents itself in a wide spectrum of morphologic abnormalities. It's important to pick up the stable from the unstable tear. Snapping knees are going to be unstable tears. If they're asymptomatic, you may observe them, but if they're symptomatic, you have to saucerize, balance, and repair.